Hello, so my name is Taka Asano. I'm working at Centrux International Hospital in Tokyo, Japan. Today, I'd like to talk about the result of the Decision QFR trial. The reasoning behind the study is that the patient risk assessment, considering the coronary anatomy and its physiological significance, which is represented by the functional syntax score, demonstrated better capability in predicting the outcomes after the revascularization in patients with multivessel disease, and compared to the one considering only anatomy. However, multivessel interrogation of the FFR may have some difficulty in the catheter laboratory because it potentially has a risk of the vessel injury and the excess procedure time. The QFR, the quantitative flow ratio, which is the FFR simulation based on the angiographic images. This potentially increase the functions and increase the practicability of the functional syntax score without using the pressure wire or the pharmacological hyperemia. Then we decided to perform this trial, Decision QFR trial, to investigate the feasibility of the QFR as a physiological information in heart team discussion determining the optimal treatment strategy. The patient population and the study design is that we included the 260 chronic coronary syndrome patients with the multivessel disease, including the proximal LAD lesion, and eligible for the revascularization. We generated from each patient both the QFR-based information and FFR-based information. Then the two heart teams were randomized to either the QFR-based information or FFR-based patient information. Then have a virtual heart team discussion and determine their optimal treatment strategy regarding their revascularization. The primary endpoint of this study was the level of the agreement of the QFR-based treatment recommendation with the FFR-based treatment recommendation as a reference. The main result of this study was the agreement between the two heart teams approach, QFR approach and the FFR approach was observed in the 91.5% of the cases. As a primary endpoint, the Cohen's kappa was 0.73, while the 95% confidence interval was 0.62 to 0.83. The assumption of the Cohen's kappa was 0.60, while the lower boundary of the 95% confidence interval was 0.40. Therefore, this trial met the pre-specified primary endpoints. And we compare the QFR measurement procedure time and FFR measurement procedure time. In this secondary endpoint, the QFR achieved the shorter procedure time compared to the FFR procedure time. The key take-home message from this trial is the heart team decision making based on the QFR demonstrated the substantial agreement with the one based on the FFR in patients with multivessel disease. In this study, we conclude that QFR potentially increase the practicability of the physiology-guided decision-making in the heart team discussion determining their optimal treatment revascularization. For further study, we need the outcome study because the current study doesn't have the outcome after the decision making.